Now, it really helps if we understand the pathophysiology, what is going on in anaphylaxis. And anaphylaxis is a severe allergic reaction. So we can get lots of allergic reactions, but anaphylaxis is a severe, systemic, life-threatening allergic reaction. So what is going on here? Well, let's think about the normal situation first. So in normal physiology, we're going to be exposed to antigens. And antigens are anything that the body recognises as being foreign, such as a bacterium or a viral particle, things we need to mount an immunological response to in order to combat, to stop us getting severe life-threatening infection. So antigens are present in the environment. If they get into the body, they're recognised by the T cells, the T lymphocytes, the T cells. And the T cells communicate with the B cells, the B lymphocytes. And the B lymphocytes are cells which produce antibodies. They produce the immune proteins. So antibodies are immune proteins. So the arrival of the antigen will cause the T cell to activate and stimulate the B cells. So now this B cell is activated. And when it's activated, it will produce lots of antibodies. And these are these Y-shaped molecules like this. Well, these particular class are. These are the immunoglobulin type E's, which are Y-shaped molecules. So it's true to say that an antigen is something which stimulates the human body to produce antibodies. And we have these antibodies. Antibodies, immunoglobulins, immune proteins are all the same thing, just different words that describe the same thing. And that's good, because what these will do is they will actually go back and they will attack the antigen. Because the antigen, as we've said, is a virus or a bacteria. It's going to have a particular proteinaceous structure. And this one's got triangular shaped proteins on its surface. And what the B cells will do is they will actually produce these antibodies that have a particular reciprocal shape to this on the surface. So in this case, the antibodies are going to be shaped like this. The antibodies have two arms and one body, the immunoglobulin type E's. But you see, that is the reciprocal shape to that, so that can fit on there. And in that way, the antibody will combat the antigen and result in the destruction and phagocytosis of the antigen. That's the antigen in there. Eradicated by the antibody. So that is the normal situation. But in allergy, this goes wrong. In an allergic situation, something which is not a threat to the body is recognised as an antigen. And in that case, we could call it an allergy, but we could also call it an allergen. So allergens. So antigens in allergy are recognised as allergens. So the antigen is an allergen in this case. It's not supposed to generate an immune response, but it does. So an immune response is generated to something which the body should immunologically tolerate. So instead of generating this antibody response to a virus or a bacteria, it's generating this immunological response to a peanut protein or a particular drug, maybe aspirin or an antibiotic, or to shellfish or to cow's milk or to whatever it is the person is allergic to. So we have the antigens being allergens, generating this allergic reaction. And what this means is that instead of having antibodies, in this case immunoglobulin type E's, which act against an invading virus or bacteria, now we have antibodies which are acting against a peanut or cow's milk or whatever it is the person is allergic to. So let's see what will happen in that case. So again, here there's an antigen. It's recognised by the T lymphocytes. That informs the B lymphocytes, and the B lymphocytes will produce antibodies to the antigen. And as we've seen, these particular ones are going to be immunoglobulin type E's. It's going to be IgE immunoglobulins. So we're going to make lots of immunoglobulin type E's to whatever the antigen is that's now recognised as an allergen. Let's say it's peanuts. Let's stick with peanuts because that's the common one. So now we have antibodies to peanuts, which we don't want. Now these will only stay in the body fluids for a relatively short period of time. But throughout the body we have another type of cell that will draw in blue called mast cells. So in the body we have these mast cells. Now mast cells derive from basophils in the blood, and mast cells are mostly in the tissues, and they are immunological cells and they regulate the inflammatory response. And on the surface of mast cells there are particular proteins like this, and these particular proteins have a high affinity for the immunoglobulin type E molecules. So what will happen is when these immunoglobulin type E molecules are generated by this antigen, which is now an allergen, we're going to end up with these immunoglobulin type E molecules, and they will actually fit into these high affinity receptors for the immunoglobulin molecules like this. So we'll have these immunoglobulin type E's now fitting onto the mast cell. So the mast cell is now expressing these antibodies to, in this case, peanuts. So this is the mast cell. And what we can see now is that this mast cell has been sensitized to this particular antibody, to this particular immunoglobulin. And that's fine until we are re-exposed to the antigen. So now this antigen here is peanuts. We're supposed to immunologically tolerate it, but we don't. So peanuts are eaten again. And what will happen is the protein from the peanuts will form a bond between the protein on the peanuts and the antibody to the peanut protein. That will stick onto these like this. So it will bind to it. So the first time that someone is exposed to peanuts, if they're going to be allergic to them, they'll make these antibodies. The antibodies will connect onto these highly specific protein receptors for the antibodies on the mast cell. And that will sensitize the mast cells. But they probably won't be any abnormal allergic reaction the first time someone is exposed to it. But there will be a sensitization. Now, these mast cells have a nucleus, of course. But the thing about mast cells is they are absolutely packed with granules. And these granules contain inflammatory mediators. So we're going to draw the inflammatory mediators in red. So there's lots and lots of granules in these mast cells. So this is a mast cell. Just write that on, it's a mast cell. Actually, this can apply to mast cells and basophils. Now, basophils are present in the blood, but certainly when I've checked my blood, I don't seem to have any. So they're basically undetectable in the blood, because what seems to happen is the basophils migrate into the tissues and they live in the tissues as mast cells. So yes, this will affect basophils if they're circulating, but most of these type of cells in the body are the mast cells. So this is the mast cell here, and these granules contain histamine and they contain tryptase, vasoactive peptides, prostaglandins, various inflammatory mediators. And when the antigen here, which is the peanut, binds onto the antibody to the peanut, the immunoglobulin to the peanut, that is binding onto these high affinity receptors on the mast cells, that stimulates secondary changes inside the mast cell. So if there's no antigen or allergen, peanut in this case, sticking onto the antibodies, nothing will happen. But then on re-exposure to the antigen, it's going to stimulate secondary changes in the mast cell. And what happens then basically is these mast cells pretty well fall apart. They degranulate, the membrane comes to pieces. The mast cell doesn't die, it reforms. But what that means is huge amounts of mast cell tryptase, mast cell histamine, mast cell prostaglandins are released. And of course these cells are present all over the body. So what that means is we get a sudden increase in these inflammatory mediators, the histamine, the mast cell tryptase, all these things. All of a sudden the level of these in the blood greatly increases. So it's just like we've given someone an intravenous injection of these inflammatory mediators and histamine. We get an acute increase in the serum levels of these substances, and they go off into the blood. Now, what does this matter? Well, it matters an awful lot, because the histamine, if we imagine that this is let's imagine that this is a bronchial passage here, leading onto the alveoli. Now, normally, of course, we want wide, patent bronchioles. But when the histamine arrives, histamine is a very powerful bronchoconstrictor. So these bronchioles will constrict. They'll narrow right down like this. And that means instead of having a nice wide passage, we've now only got a narrow passage for the air to get in and out. So histamine is a powerful bronchoconstrictor. And that's going to clearly cause breathing difficulties in sensitive individuals. And as well as that, the histamine acts on the blood vessels as well. And in blood vessels, histamine is a very powerful vasodilator. The blood vessels become very wide like this. So histamine is a bronchoconstrictor and a vasodilator. So now we've dilated many of the vessels, particularly at the level of the arterioles. Now, when we vasodilate, we reduce the peripheral resistance, and that's going to reduce the blood pressure. So vasoconstriction will increase the pressure in the vessels. Vasodilation will reduce the pressure in the vessels. So if this is happening all over the body, then we're going to get acute hypotension. The blood pressure is going to be reduced. The heart will beat faster to try and compensate, but basically we get all this vasodilation. This is also why we get the redness in anaphylactic reactions. And as well as that, because the histamine is a vasodilator, it's also going to act on the smaller vessels. It's going to act on the capillary. It's going to act at the level of the capillaries as well. And we're going to vasodilate the capillaries. And that means tissue fluid can get out into the tissue spaces. And we're going to get edema. And that's going to further lower blood pressure because we're depleting blood volume as well. So we can explain why the anaphylactic reactions are so life-threatening, because they are bronchoconstricting, vasodilating, and increasing the permeability of capillaries, giving rise to breathing difficulties and possible circulatory collapse. So this is what is going on in these severe allergic anaphylactic reactions. And it's interesting because this also explains the management, the treatment of this condition. So the life-saving treatment in an anaphylactic reaction is to give adrenaline. Now, histamine is bronchoconstricting and vasodilating, whereas adrenaline is bronchodilating and vasoconstricting. So it does the exact opposite of the histamine. And it also explains why we use antihistamines such as chlorpheniramine, because these counter the histamine-induced vasodilation and bronchoconstriction. And we also use steroids because these shorten protracted reactions. We know steroids are good for treating asthma. That's why we give a hydrocortisone. And also because the steroids are anti-inflammatory, they're going to act against the inflammatory mediators released by the mast cells. It also explains why we give salbutamol, which is a bronchodilator if the patient has got wheezes and difficulty breathing. And it also explains the main investigation to diagnose this condition, which is to look for the presence of mast cell tryptase, which is released from the mast cells. Best to take that about 1.5 hours after half an hour to an hour and a half after the occurrence. The peak, the half-life of mast cell tryptase is about 2 hours. Now, histamine has a much shorter half-life than mast cell tryptase, but the point is this reaction can keep going for some time, so we can get ongoing degranulation. That's another reason it's good to cover with steroids. And it's also why we have to admit these patients for ideally 24 hours, but at least 12 hours of fairly close observation to make sure the reaction is fully over.